So the subject that we are going to be talking about is one that is sort of near and dear to my heart because it's what I get most of the questions about when I do take some of the phone calls for the Global TB Institute on managing tuberculosis. And I recognize a number of your names on the side there from having spoken to you over some of these phone calls. So I am an infectious disease specialist here in Camden, although I actually live in Pennsylvania. So I sort of span both sides of the river. Rather than talk too much more about me, let's just talk about, I am one of the medical consultants for the Global TB Institute, which is one of the 4 TB centers of excellence in the United States. So once every 6 or so weeks, if you call the TB hotline or put in a medical consultation request electronically, you will get me as your consultant, which doesn't necessarily mean that I know all the answers, but I have a large pool of additional consultants that I often ask when we have difficult questions. And I was just saying that the questions that we get seem to get more and more complicated each year. So our objectives today are to focus on side effects and adverse effects of anti-tuberculous medications. And one objective is to sort of understand what we mean and how we monitor for adverse drug reactions from TB medications. We're going to talk about the most common types that we see and which medications cause which problems. But then the bulk of this talk is really a practical approach to managing the most common adverse drug reactions that we see, including GI toxicity, hepatotoxicity, skin stuff, and others. I have a full slide set here, but there are a number of cases that are embedded into it that have some questions. I am always overly optimistic about how much material I can cover. So the last couple of slides deal with less common adverse reactions that we may or may not have time to cover everything, but we'll see what we can do. But I think to start with, I think it's important to understand that we can make lots of errors in terms of how we manage adverse reactions in patients. And I think when we talk about errors and medical errors, it's important to recognize that not all errors are preventable. I don't know how many of you are baseball fans, but this is probably the picture of the most famous error in baseball history. This is Bill Buckner in the 1986 World Series playing for the Red Sox. And here is a picture of that ball going through his legs into the outfield. And the Red Sox lost the game to the Mets, the hated Mets, if you're from Philadelphia like I am. Obviously, nothing that you could do about that error. It was just a mistake. However, this is an example of an error that's entirely preventable. For those of you in the Philadelphia area, you might recognize this is Rhys Hoskins, who is the Phillies' first baseman. And here you can see him not playing first base, but here he is out in left field, where he should never, ever have been playing. So if you put somebody who can't play left field in left field and expect him to not make errors, then that mistake is on you and not on him. So the purpose of this talk is to give you the knowledge to help you be better trained so that you won't make errors when it comes to managing TB adverse reactions. All right, so we're going to start with a case, and here is our first one. This is a 63-year-old Vietnamese-born woman who is diagnosed with smear-positive pulmonary tuberculosis. Her gene expert is MTB positive, rifampin resistance not detected. She started on 4-drug therapy and is receiving her treatment by directly observed therapy through one of the local clinics. About 2 weeks into treatment, she complains to her clinic nurse that the medications are making her sick and she wants to stop them. So here is our first question. So is she having an adverse drug reaction to her anti-tuberculosis therapy? And here's a couple of choices. You can read them here, and then we're going to see what people think. A lot of these questions may not have a single right or wrong answer, but just to sort of get a sense of how you all feel about this. All right, so let's see how the polling is going, and we'll give you a little more chance to read the choices and put your 2 cents in.
All right, it looks like answers are closed, so I'll go ahead and close it.
Okay. So let's see how we all thought, okay? So almost all of you answered that you can't tell, which I think is probably the most appropriate response here, is until you've evaluated, you don't know the answer. These could be expected side effects of her medication, but they could be markers of something more serious going on. And so that means that part of what you need to do is you need to assess. You may presume that these may not be serious adverse reactions, but you don't know that until you've done a thorough vetting of them. All right, so let's talk about what an adverse drug reaction is. There are a number of different definitions that are used, but we're going to use the World Health Organization definition here, which is a response to a drug that is noxious and unintended and occurs at doses normally used in man for prophylaxis, diagnosis, or therapy, as opposed to people who might deliberately overdose by swallowing a bottle of their anti-tuberculosis medications. And when we talk about adverse drug reactions, the most common types are what we call augmented or idiosyncratic reactions. An augmented reaction being something that would be an expected effect of the medication, but perhaps occurring more severely than you'd expect. For example, if you give someone a pain medication that might make them drowsy, if it makes them overly sedated, that would be an augmented adverse drug reaction. Whereas many of the anti-tuberculosis reactions that we see are idiosyncratic, they're not necessarily predictable when you prescribe the medication, and you can't tell who may get them. Now, the title of this talk uses the term side effects, and side effects, most adverse drug reactions are really side effects, but they're generally considered to be more severe, whereas side effects, as we generally use the term, and this is a term that the pharmacologists that I work with hate, but we all use it anyway. Generally, side effects refer to milder, more predictable effects from taking a medication, whereas an adverse drug reaction we generally use for more serious effects. An example of a side effect would be urine turning orange from rifampin. Another term that people use is adverse drug events, and that's mostly used when you look at data from clinical trials, because they can't always assign blame and say that this is definitely an adverse drug reaction, but it's an event that occurs meeting a certain defined criteria while a patient is on treatment. It doesn't prove causality, but from looking at data on frequency of events in large trials, you can get some idea of how common adverse drug reactions are. All right, so that's an adverse drug reaction. What constitutes a significant adverse drug reaction? And a significant adverse drug reaction meets any one of these following criteria. You have to stop or change the drug therapy, or you may have to modify the dose. And those are things that I have bracketed here because those are the sorts of things that are relatively easy to manage in the clinic setting. The ones below that, however, are things that are usually beyond our ability to manage in the clinic. They may end up in the hospital. They may end up in the hospital for a long period of time, or they may have to stay longer than they would otherwise if they didn't have that reaction. They may need supportive treatment like dialysis or temporarily on a ventilator. It could negatively affect their prognosis, or the most severe is temporary permanent harm, disability, or death. And obviously, those are things that we want to try and avoid. And in order to do that, we monitor for them. And so that monitoring process is a process that starts before you initiate therapy, but then continues throughout the entire treatment course. And what you want to do when you are monitoring in your initial assessment is you want to assess for factors that increase the risk of someone having an adverse drug reaction. And what we're talking about today would be to anti-tuberculosis medications. But I think just as important and sometimes overlooked is that part of that monitoring assessment also includes patient factors that may delay the recognition of an adverse event if one occurs. And I'll give you some examples in a second. So things that we know might increase your risk of an adverse drug reaction. One of those is age. We know that our patients who are older generally are more likely to have medication reactions in general to any medications, including ours. If they have certain underlying medical conditions like pre-existing liver disease or neuropathy, but that risk is also modified by what concomitant medications and supplements they may be taking. Behavioral factors, such things as are they drinking alcohol, which we know is going to interfere with how well they tolerate potentially hepatotoxic medications. But the other aspect of this are there any barriers to effective monitoring of an individual who's on medication? Because monitoring includes in part the ability of them being able to tell you what's wrong. Are there language or cultural issues, psychiatric issues that interfere with your ability to adequately monitor? Or on the other hand, are they a patient who has general illness anxiety disorder, meaning that they're going to complain about side effects to everything no matter what is happening? And being able to understand this ahead of time is important as you follow these folks during the course of their treatment. And then the other component of monitoring for adverse drug reactions is baseline laboratory monitoring. And that includes that panel of baseline laboratory tests that we get before we initiate treatment in everybody. And when we talk about prescribing anti-tuberculosis therapy, every decision that we make here, and in fact, every prescribing decision in medicine is really a risk-benefit analysis, meaning are the benefits of treatment going to outweigh the risk that we are subjecting this patient to? When we treat TB disease, the benefits always, I'm not going to say always, because there are very rare cases where you might not treat TB disease, but almost always treatment of TB disease, the benefits outweigh the risks. However, those who are at higher risk are going to need to be monitored much more carefully. When we talk about treatment for a latent TB infection, we're weighing risks of treatment, which means toxicity, versus the benefits We know that those who are at highest risk of developing TB disease should always be treated, even if there are some risks, and that with our newer regimens that you heard about yesterday that are safer and of shorter duration, almost all individuals can be safely treated for latent TB infection because the benefits will outweigh the risks in nearly all instances using some of our safer and shorter regimens. All right, so we know that the benefits of we know we can quantify what the benefits of treatment are in any individual. So that in this scale here, if you're looking at that purple cup is always filled to the same degree. We know that latent TB treatment prevents them from developing TB disease, and TB disease treatment prevents them from getting sicker and from spreading disease. But can we modify the risks as we prescribe TB therapy? And there are a couple of ways we can do that. One is that we have to choose our regimens carefully based on that patient's individual risk. We can do behavioral interventions such as ways of trying to keep them off alcohol-free during the duration of treatment. And part of it is up to us to having a strong monitoring plan and then being able to respond quickly when problems do arise. All right, so let's start instead of, now you have sort of the theoretical basis for monitoring for adverse events. Let's talk about the most common types of drug toxicity that we deal with. And the top four are the ones that I'm going to spend most of the time on, but there are others that we'll also mention and may or not have time for cases on. The major ones that we see, there's gastrointestinal toxicity, there's hepatotoxicity, there are hypersensitivity or allergic types of reactions, as well as other dermatologic reactions that may not be manifestations of hypersensitivity, and some of the less common but still relatively frequent ones we see are joint symptoms, neuropathy, visual symptoms, drug fever, and then a few others that I've listed on this slide. So as we monitor for these toxicities, this is a collaboration between our clients, our prescribers, and our TB programs. Now, sometimes the TB program is the prescriber, which makes things simpler, but sometimes this is a triad, not a dyad. So somebody's prescribing, the client is taking the medication, and the TB program is the one supervising. So the stronger those collaborations, the better. Part of this is client education, and this is ensuring that they are educated about potential serious adverse drug reactions from their medications. And I will tell you the single biggest challenge that I deal with and that the folks in our clinic out in Belmar deal with is really how do you educate patients without creating unnecessary anxiety about those side effects. And I will tell you there is no right and no single way to do this. And part of this is really seeing your clients and making an assessment of how they process information and how they're going to deal with things. I wish I could give you clearer guidance here, but I think that this is probably the thing that is most tricky and that you have to develop a little bit of a feel for. You have to make sure that your clients understand the need to tell you when they're having problems, but just because you've told them, don't presume that that means that they will tell you. It's amazing how many times somebody will show up in a clinic session and I'll see them and they'll report a side effect that they've had for 3 weeks that they never mentioned to the person who was doing their directly observed therapy. So we always get surprised. So, but you can be surprised if you ask them and they deny it. But if you're surprised because you didn't ask about it, then that error is on you. Staff need to be educated about the awareness of potential serious adverse drug reactions, the need to assess for adverse drug reaction symptoms or potential symptoms every time you interact with your clients, and the need to document them. This is especially true where there may be multiple providers who are looking at the chart and interacting with the client, because if something bad has happened but it's not documented and you don't know about it, then you're going to make decisions in a little bit of a void. And obviously there are lots of opportunities for interaction between us and our clients. All right, so, there we go. So we talked about these reactions. There are mild and more severe ones. Mild reactions on the left are usually things that have no lasting effects. Almost always you can power through them and don't have to change your regimen, but you can use simple interventions like timing of medications or use of over-the-counter things like steroid creams or antihistamines to help manage them. More severe reactions require more aggressive interventions. They almost always require more intensive monitoring, meaning they're going to need more blood draws. They're potentially life-threatening if you ignore them. You may have to stop medications. If you make people really sick, they may end up in the hospital. And some examples that you've probably all dealt with are bad liver toxicity or severe dermatologic reactions. The worst cases are severe morbidity and even death, such as fatal hepatitis. I don't think we've had any of these in our clinic in the last couple of years, but these things do happen. But more commonly, these are people who need more intensive clinical and laboratory monitoring, more frequent office visits, and they need alternative, more protracted and potentially less effective treatment regimens. And just from my perspective, if you are treating a TB patient who has multiple adverse drug reactions, that is as challenging or even more challenging sometimes than treating multi-drug resistant tuberculosis, which you all heard about yesterday afternoon. And it is also true, at least in the region where we are, that patients with multiple adverse drug reactions are much more common than patients with multi-drug resistance. Now, that may change over time, but at least for now, that we have many more patients who are on complicated regimens and second and third line drugs because of adverse drug reactions to first line medications. But the biggest thing is that if someone has an adverse drug reaction to a medication, you already have someone who is more skeptical about everything else that's going to happen to them during the course of treatment. It interferes with compliance and therefore potentially interferes with outcomes. So that is part of the reason why we have to be very proactive and assess potential adverse drug reactions very seriously and aggressively, because if we don't, we're going to lose that collaborative care model that we're trying to establish with the folks that we're taking care of. All right, so these, you've all seen this picture before. These are our first-line anti-tuberculous medications. I've added rifabutin and rifapentine to the list here because they're used as alternatives to rifampin in a number of settings. So those are our first-line drugs for susceptible disease. And here are our second-line drugs, or second and third and even beyond drugs, drugs that are used for resistance and intolerance. We use lots of fluoroquinolones, so when I talk about reactions to first-line medications, I usually incorporate quinolones there because they're so widely used in treatment. but there are other drugs that are now becoming increasingly important that I may mention briefly along the way because of specific toxicities. But you heard more about these in your treatment of multi-drug resistant disease talk yesterday, and those would be linezolid and bedaquiline, as well as a long list of other drugs that we occasionally use here. All right, so we have our first-line drugs and quinolones, and this is just sort of a global overview of what drugs do what. These are the expected or occasional adverse drug reactions to first-line agents and to fluoroquinolones. And you'll see this slide again as we go through some of these. But what's important to recognize here is that some of these adverse drug reactions are very specific and are only caused by certain drugs. For example, optic neuritis is something that we worry about with ethambutol. And in somebody who's not on ethambutol, it really is not much of an issue most of the time. On the other hand, gastrointestinal toxicity can be seen with any of the drugs we prescribe. Hepatotoxicity with most or all of them, and cutaneous adverse drug reactions can be seen with anything as well. Doesn't mean that they're seen with all of them with equal frequency, but you at least have to think about any of these drugs as being a potential culprit. So how common are adverse drug reactions to TB medications? Pretty common, actually. So let's talk about latent TB regimens. And when we're treating latent TB, we're often treating healthy, well individuals. We're using limited numbers of drugs in a regimen, one most of the time, or occasionally two if they're on isoniazid and rifapentine. We have lots and lots of data over the years on INH toxicity and increasing data on toxicity from the other regimens and recent comparative data from large clinical trials that sort of validate what we've always thought. On the other hand, when we're treating TB disease, we're using a regimen of multiple drugs. The toxicities of these drugs overlap, and it is often much more difficult to assign the blame for an adverse drug reaction. All right, so INH toxicity by age if they're just getting isoniazid. And so this data is from an earlier review from a number of studies, but the data is pretty much stood up over time. And you can see, so these numbers are not in percents, they're actually in incidence per thousand. So you can just move that decimal place one to the left to give you a percent. And you can see that the incidence of hepatotoxicity goes up as you get older, reaching about 3% over age 54. Now, how does this stack up with some of the recent studies? So this is the large Prevent TB trial comparing 9 months of isoniazid versus 12 weeks of isoniazid and rifapentine weekly. And you can see, just looking in the red box here at hepatotoxicity, the incidence of hepatotoxicity as an adverse event, not as a drug reaction, because this is a clinical study, was about 2.7% overall, but it doesn't tell you what the severity was. And you can see the incidence of hepatotoxicity in the 12-week regimen was much, much lower, although there were other types of adverse events that occurred with higher frequency that we may talk about later on. This is another trial comparing 9 months of isoniazid versus 4 months of rifampin. And again, in this trial, toxicity from isoniazid, which was almost all hepatotoxicity, occurred at about 2%, being a severe adverse reaction, whereas the adverse events from 4 months of rifampin were much less. and hepatotoxicity was also much, much less. All right, so we talked about treatment, latent TB treatment regimens. What about during the treatment of TB disease? This is probably the most widely quoted study. This is about 400 patients from the Montreal Chest Institute, a retrospective review of about 400 adult patients, and 10% of them almost had major adverse drug reactions leading to discontinuation of at least one medication. So that's a pretty high percent of the people that you're treating for TB disease. And of those who had an adverse drug reaction, a quarter of those, or 9 of them, had a second one. So that means that if you've had one bad thing happen to you, you are statistically more likely to have a second bad thing happen to you. And I think that's been our experience as well. The major reactions that they saw were rash and fever, hepatitis, and other GI toxicities, but a couple of trends that they noted that have pretty much been seen in a lot of other studies are that the rates were much higher in women than men and much higher as you got older. This just shows you the type and the drug association, and these numbers vary in different studies, but in general, this is what they saw in terms of rashes. In this study, their biggest culprit was pyrazinamide, the open boxes here, as a cause of rash, followed by rifampin, and least was isoniazid. However, in our clinic, we see almost as much ethambutol cutaneous reactions as anything else. You can see here, pyrazinamide was their leading hepatitis culprit, followed by isoniazid. GI toxicity evenly distributed amongst isoniazid, rifampin, and pyrazinamide. And here's ethambutol, the only culprit for visual toxicities. And again, we already talked about this, but you can see the tremendous difference by gender and by age. So what this is the proportion who don't have a side effect over time by days of therapy. And the upper curve on the left is males, and the lower curve is females. And you can see that the proportion without a side effect in women is much smaller by the end of a month or two of treatment. And you can also see the same thing when you compare age brackets, and that cohort greater than 60, much more likely to get into trouble. All right, there are a couple of other studies that have give you data, and the data for all these studies isn't always concordant. There was a study from the UK in which 5% had adverse drug reactions requiring treatment modification, but they also saw the same trends in female greater than male, and significantly higher in age over 60. Another study from Lima, Peru, where obesity and smoking were associated with adverse drug reactions, as was multi-drug resistant disease, but there we're using more and more drugs with additional toxicities. Now, here was an interesting small study from China where the incidence of adverse drug reactions was as high as 22%. Mostly liver and GI toxicity, which sort of raises the question, why are there such variation in adverse drug reaction rates in the different studies? And you have to think about where were these studies done and what was the makeup of the treated population. And one of the things that we are learning more and more about is the science of pharmacogenomics, that there are metabolism differences that result in higher rates of drug reaction, in part due to metabolism that leads to higher drug exposures, as well as other genes that seem to affect the way we respond to medications. This is not going to be a lecture on genetics, but I think it's important to understand that the genetics are informing our understanding of these reactions, And in a recent study that was published looking at patients who developed acute drug-induced liver injury while they were on isoniazid and rifampin, if you mapped their genetics, there were a number of different genetic pathways that seemed to be associated with increased incidence of drug reactions. And as we get further and further into this, we may be able at some point in the future to genetically profile patients to see who we can predict is likely to have a problem. Now, I'm not going to focus on treatment of multi-drug resistant disease, but you can see that if we think that adverse drug reactions are common in susceptible disease, it's much, much more common with multi-drug resistant disease. And in this one study that was published, 83% of patients had more than one adverse drug reaction while on treatment for multi-drug resistant disease. And you can see that for all the different drugs that are listed here, that rate is highly variable, as high as 10 to 15% for some of the more toxic medications. All right, so now you have the background. The rest of what we're going to talk about is going to be the management of some common adverse drug reactions to anti-tuberculous therapy and what is the state of the art. And I think this defines the state of the art. This is essentially our management strategy for most common adverse drug reactions, stopping medications or stopping a different medication or stopping all their medications. And so this is what we're going to go through. These are just some general principles of approaching adverse drug reactions. Part of it involves that baseline evaluation and preemptive monitoring. And then when we evaluate signs and symptoms in a patient, like that case that we just talked about earlier, who felt her medicines were making her sick, does she have risk factors for toxicity? Do they have other things going on that could account for their symptoms? How severe are their symptoms and potential toxicities that are going to inform our action plan? And then if we do manipulations, we have to make sure that we're continuing to follow them. All right, so let's go back to our Vietnamese woman who we are going to interview using our interpreter phone to make sure that we have a full understanding of what she's talking about. And what she tells us is that when she takes her tuberculosis medication, she feels sick to her stomach, like she might throw up, and she can't eat. She hasn't been vomiting. She doesn't have dark urine, and she doesn't have abdominal pain. She has lost about 2 pounds in the 2 weeks since she's been on medications. She does have lab work done. She has an ALT that is mildly elevated from her baseline and a normal bilirubin. All right, so what's the most likely explanation for her symptoms? Okay. So let's see what we have here. Most of you think that it's gastrointestinal toxicity. We've determined it's not hepatotoxicity because the liver enzymes are okay. And although if you were a betting person and trying to win a fortune at the at the casinos now that they've reopened again. You might pick your favorite, but the answer is you don't really know which one is causing the problem. So how are we going to try and manage her? Which of these might be your initial strategy to see how you could help her to be able to take her medications without problems? Okay. All right. So most of you are going to try something simple, like trying to give the medications with food, or maybe later in the day or at a different time, to see if you can get her to do better. And that's probably, I think, the strategy that most of us would try once we've decided this is not a serious or life-threatening problem. So let's talk a little bit about gastrointestinal toxicity. And so those are symptoms: nausea, vomiting, diarrhea, bloating, anorexia, abdominal pain. So all things that people complain of commonly, can be mild, can be severe. One of the things that it's clear is that you can't tell which of these symptoms necessarily reflects hepatotoxicity. So it's very hard to rule out hepatotoxicity unless you're going to get liver enzymes, including transaminases and bilirubin, to say that it isn't. Now, typically, bloating or diarrhea would be less likely as causes of hepatotoxicity, but nausea, vomiting, and even abdominal pain, and certainly anorexia, could be manifestations of hepatotoxicity. And which drugs are most likely to cause it and when? Well, as we already discussed, almost any drug can potentially cause GI toxicity. It often occurs early, within the first few weeks of treatment. People generally don't tolerate their medicines fine, and then all of a sudden start feeling sick every time they take them unless there's something more serious going on. The hierarchy in most of the published studies is PZA more commonly than isoniazid, then rifampin, then ethambutol. However, in our clinic, that order is actually reversed. We probably see more gastrointestinal toxicity from rifampin and rifamycin than from isoniazid. Again, I don't know if that is a patient related issue or a genetic issue, but I think that we actually find more problems with rifampin. When you get fluoroquinolones, can also cause toxicity and probably are in the middle there. A little bit less common than isoniazid and rifampin, more common than ethambutol. Many of the other second-line drugs can also cause toxicity. Pretty much the only ones that almost never do are the injectable drugs, but they cause a lot of other toxicities. How do you manage them? You can play with the timing of the dose. You can give the medications with food, but this is a little bit challenging because the absorption of many of our medications is actually decreased when you have people take them on a full stomach. So you want to give them with something, but not necessarily, fill them up before they take their medications. If somebody's on intermittent therapy, which we use less of in our clinic now than we used to, and it's too many pills and they're having problems with that pill number, they may do better with a smaller number of pills on a daily basis. You can use antacids. for people who are anxious because they get nauseous just thinking about the medications. You can use an anxiolytic and you can use antiemetics. And here are some of the antiemetic options and what the doses are. Some of these are antihistamine drugs like hydroxyzine and promethazine. And then there are traditional antiemetics on the list. And we actually do pretty well in our clinic with promethazine. Occasionally have to use Zofran or one of those drugs, and occasionally some of the others because there is patient variability in response. Diarrhea is less common. The most common drug we typically see it with is fluoroquinolones. It's less common with other first-line medications, but can occur. Usually it improves after the first several weeks. We worry about C. diff infections, especially in those patients who have recently been in the hospital and where the risk of C. diff is higher. We also, we almost never use the liquid formulation of isoniazid because that seems to cause diarrhea commonly. You can use probiotics. You can, if you've ruled out C. diff infection, use things like loperamide, but you don't want to use that continuously throughout the treatment course. All right, so let's move on to our second case. This is a 34-year-old woman from Ecuador with pleural tuberculosis that was diagnosed about 6 weeks postpartum. She was started on 4-drug therapy and is now in about her 5th week of treatment. She complains of some mild nausea on her clinic visit, but she looks a little bit yellow to you. Her abdominal exam is normal. There's no liver tenderness, but here are her liver enzymes. Her ALT is 732, which is more than 10 times the upper limit of normal. Her AST is 444, which is, I guess, about 9 times the upper limit of normal, and her bilirubin is elevated. What should we do with her? Okay, so I think most of you said that you would stop everything. And that is probably the safest thing to do. Some of you said you would stop isoniazid, rifampin and pyrazinamide, and then add some additional drugs. And I don't think that's a wrong answer. And we'll talk about when you might choose A and when you might choose D. So let's talk a little bit about hepatotoxicity. Let me make this disappear. Here we go. So obviously, so the technical term for hepatotoxicity is drug-induced liver injury, which would be elevation in liver enzymes, and usually the one we follow is the ALT, but the others can be elevated as well, and it's very rare that we just get a single ALT value. We talked about confounders earlier, but other drugs, supplements, alcohol, underlying liver and biliary disease, And every once in a while, we'll see somebody who actually has biliary tract or liver involvement from their TB, and the liver enzymes are actually part of their disease and get better as their TB disease is treated. Can be symptomatic or asymptomatic. And we know that up to 20% of people started on isoniazid have mild, non-significant transaminase elevations that don't require stoppage of therapy. The symptom-related threshold to stop therapy is an ALT more than 3 times the upper limit of normal. The asymptomatic threshold is an ALT more than 5 times the upper limit of normal. We do see occasional fulminant hepatitis and even, unfortunately, fatal hepatitis, which I think the best estimates are anywhere between 4 and 7 per 100,000 isoniazid courses. These are some risk factors for hepatotoxicity. Age we've talked about before, malnutrition, PZA being in the regimen seems to contribute a lot to toxicity, being on other hepatotoxic agents, alcohol, pregnancy or postpartum status, as this woman was, elevated liver enzymes at baseline, underlying HIV infection, people with multiple medical problems, probably because they're also on multiple medications, and pre-existing chronic liver disease, including chronic hepatitis. And then there are genetic factors that are a little bit harder for us to predict, at least at this point in time. And this is sort of the general schema that we've already talked about when you would hold treatment. In general, these are when their transaminases are elevated 3 times or 5 times the upper limit of normal. However, it's important to recognize that people who have underlying cirrhosis may not show much of a transaminase elevation, and they may only show an elevation in bilirubin. And most of us, if we see that bilirubin shooting up, even without the transaminases shooting up, are going to be worried about hepatic toxicity. So from a practical perspective, what do we do in somebody like this who has some symptoms and LFTs that are far above this threshold? We're going to stop all the medications. And then what you do is really a function of how bad their underlying tuberculosis is. If somebody is very sick from their TB and needs to be maintained on treatment, you can, depending on how bad their liver enzymes are, you might keep them on rifampin, ethambutol, and a fluoroquinolone, or you might stop the rifampin so that they're on no potentially hepatotoxic drugs, and then add some additional drugs to make sure they're on some treatment while you sort this out. You're going to assess for concomitant medications, supplements. Patients almost never tell you about some of the supplements that they're taking that some family member may have sent them or given them. You're going to look for viral hepatitis, and obviously that includes hepatitis B and hepatitis C. But we also, not so much this year, but certainly in the year or two prior to this, when we were having large outbreaks of hepatitis A in our injection drug use and unstably housed populations, acute hepatitis A is always a consideration. So let's say you've stopped the medication, their TB disease isn't too bad, so they can afford to be out without it for a while. What do? Well, you want to make sure their liver enzymes are getting better, because if they're not getting better, even though they're off of medication, then you probably need a liver specialist to help you. But if their liver enzymes fall, then usually when they get down to around twice the upper limit of normal is when we start to re-challenge them. Some folks can go back on their original regimen and in re-challenge and do just fine. But some of it you are going to weigh based on how bad their hepatotoxicity was. You can either sequentially re-challenge them, meaning starting a drug, monitoring their liver enzymes, and then adding another one and then another one. From a practical perspective, this generally means doing it about every 7 days with liver enzyme monitoring. If you do this, most of the time, we start with either rifampin alone or rifampin plus ethambutol because we consider ethambutol not to be hepatotoxic. And then you would add in isoniazid, and you may or may not add PZA back, depending if they're doing fine on the other drugs and they had really bad hepatitis, you might not choose not to do that. If while on this, they start to have symptoms again or increasing liver enzymes, you have to stop the last drug that was added. And there have been actually some evidence base about what the best way to re-challenge people is. There was a study that actually looked at whether you threw them back on the initial regimen, or you did sort of once a week sequential addition, or sort of did an escalating drug dose in sequential. And in this study, it turns out that it really didn't make any difference which way you did it. And although starting all the drugs back at once probably had the highest rate of recurrence of symptoms, and about 90% of them had successful reintroduction of their TB therapy without recurrence of hepatotoxicity. So severe hepatitis does occur. So you have to be aware of it, and this is a case that sort of illustrates some of the features. This was an 11-year-old from our region who had a conversion tuberculin skin test as a contact of a household case, was otherwise well, normal chest x-ray, was started on isoniazid, was receiving directly observed therapy, which is not typical for 11-year-olds in our jurisdiction, but there were concern about parental compliance. So directly observed therapy was being done, but then after about a month, this was transitioned to the school nurse. He was well at a month when she was seen in the clinic. And then about almost 3 months into her course of therapy, she was brought to the emergency room with yellow eyes, decreased appetite, nausea, and fatigue for about a week. She was icteric, and you can see that her liver enzymes were quite high here and continued to go up for a few days before they finally started to come down. Severe isoniazid liver injury still occurs. This was from a review in the MMWR from 2010, and they reviewed 17 cases. It's really hard to figure out what the rate of this is because there was no denominator. And of these 17 with severe hepatotoxicity, 5 of them died and 5 of them required liver transplantation. A couple of points are that this can occur anytime in treatment. These are idiosyncratic reactions. Just because you make it through the first month or two with no problems, it's something that can crop up at month 5 or even month 6. It can occur in children. The hepatitis was often diagnosed by people other than the prescribing physician, and in half of them, even though they had symptoms, the medication was not stopped. So it's just something to be aware of. It's very uncommon, but you never want to miss this. All right, now we talk a lot about hepatotoxicity from isoniazid and pyrazinamide that occurs less commonly with rifampin. But when it does occur, the pattern is a little bit different. It is typically what we call a cholestatic pattern, meaning the bilirubin and alkaline phosphatase go up more than the transaminases, and often is associated with fever and other manifestations of hypersensitivity. This is something for which you almost always have to stop the medication, but It is also one of the toxicities from rifampin for which you can actually re-challenge them with rifabutin, and more than half of them will be able to tolerate rifabutin without a problem. Okay, so let's move on to our third case. This is a 74-year-old Korean man with recently diagnosed pulmonary tuberculosis. He has a positive acid-fast smear, which is rifampin susceptible MTB by gene expert. He has a history of diabetes and chronic kidney disease. He weighs about 134 pounds. His baseline creatinine is about 1.7 with a calculated creatinine clearance of 35. He is started on daily isoniazid, rifampin, pyrazinamide, and ethambutol with B6. He comes back to the clinic 2 weeks later. He's doing better. His cough has improved. He's gained a couple of pounds. However, you happen to look at his back and you see this rash, and now he tells you, like, yeah, I've been a little bit itchy. How are we going to manage him? Okay, so we seem like we're in agreement that we're not going to stop everything. Some of us are going to ask more questions and see what else we can find out. And some of us are going to look to see if there's any mucous membrane or other more severe manifestations that might make us more worried. And I think both of those are appropriate responses. So let's talk a little bit about cutaneous adverse drug reactions to anti-tuberculous therapy, or the abbreviation is CADRs. You can see these just on the skin or as part of a more generalized hypersensitivity reaction. The epidemiology and the rates of these are less well characterized than for GI and hepatotoxicity. I already showed you the data from the Montreal Chest Institute, but in our clinic, we see as much ethambutol skin reactions as anything else. They're more common in people with HIV, and they're more common in those individuals who have history of multiple drug allergies. What the drug rash looks like is very important, because there are clearly things that look more like drug reactions, and there are things that look like they're probably due to other things. One of the challenges is that we are not dermatologists, although sometimes we are asked to be dermatologists in the clinic. So we ask the 4 W's. Where did it start? What does it look like? What makes it better or worse? Does anyone else at home have it? If everybody at home has the same rash and only one of them is on anti-tuberculous therapy, it's probably not your drugs. There's a long differential of other skin rashes that people can have. The problem is that your clients will always blame their medications regardless of the cause, and it's up to you to try and come up with reasonable explanations other than their medications. Now, there are specific skin reactions that are associated with different drugs. Acneiform reactions, which we see not uncommonly, mostly reported with isoniazid, but also with rifampin. We know that some of our medications cause photosensitivity, pyrazinamide, and also fluoroquinolones, and patients have to be warned about that, especially when it's not raining and it's warm outside. We do see purpura from some drugs, lupus-like syndromes, and then there are a few other uncommon ones like pellagra that is seen with isoniazid, but then exfoliative dermatitis and toxic epidermal necrolytis and Stevens-Johnson syndrome. The severe ones, as well as urticaria, can be caused by any of our anti-tuberculous medications. So minor rashes are generally localized, are often more pruritic than actually skin involvement. They can be maculopapular, but if there is no if there's no mucous membrane or systemic involvement, then you can try and manage these without stopping their anti-tuberculous medications. Sometimes they will clear up on their own. Sometimes they will respond to use of antihistamines and topical steroids, but you have to carefully monitor them to make sure they're not progressing or developing symptoms other than just their rash. We do occasionally see flushing and other dermatologic reactions. Most commonly, rifampin and pyrazinamide can do that, as can the other rifamycins, and typically occurs a couple of hours after taking the medication and resolves. When we talked about photosensitivity, hives can be caused by anything. If somebody has severe hives, you might then have to stop all of the potentially responsible medications and re-challenge, but you mostly want to make sure, because hives can be mild, but hives can also be a marker of more severe hypersensitivity. There are regimens for desensitizing if somebody has a really severe reaction. And for patients who have mild urticaria, you can also use antihistamines and pre-medicate them. There are regimens for re-challenge. There are also regimens for desensitization, but almost always desensitization would be done in an inpatient setting and only if use of those medications is critical to your treatment management. These are the reactions that we worry about the most, these generalized erythematous reactions. And when you have these, you have to stop the drug, all of your drugs immediately. If they have fever or mucous membrane involvement, you're worried about these more severe syndromes like toxic epidermal necrolysis, what we used to call Stevens-Johnson syndrome, or DRESS syndrome. Again, just like with hepatitis, if disease is severe, you're going to use 3 new drugs. You might have to give steroids. And then if you have to go back and re-challenge them, this is an instance where you're going to re-challenge serially. You can introduce the drugs a little bit faster than you can with hepatotoxicity, because if people are going to develop a skin reaction, they'll develop it fairly quickly. You might want to look at their eosinophil counts, but if they have severe disease, you want a real dermatologist to see them, not one of us amateur dermatologists. Petechial reactions are mostly, we worry about rifampin, which can cause rarely thrombocytopenia, and this is one of those rifampin toxicities that you can't re-challenge people for. If you are using any linezolid in your clinic, linezolid, this is a common toxicity long-term from linezolid as well. Now, we talked a little bit before about whether or not you can use another rifamycin instead of rifampin, and that means rifabutin. And I don't, so we can, so what do you think about the use of rifabutin here? Can I give them rifabutin instead? So the answer here is really that it depends on what their reaction might be. Some of the rifampin reactions, actually, we're very successful at re-challenging. For example, 70 to 80% of the time with hepatotoxicity and Intestinal toxicity, rifabutin seems to be okay. The success rates are significantly lower for some of the severe dermatologic reactions, but not zero. So if you do it, you have to monitor them carefully, and this is where you would want to consider getting some expert advice. All right, so we're going to just finish up our case 3, who has another problem. And then I think rather than going through some of the rest of these toxicities, we'll jump to time for questions and discussions. So here is our same patient, our Korean gentleman. He was sequentially rechallenged after his medications were held and has tolerated them. We know that his isolate's pan-susceptible, so he was not restarted on ethambutol, so perhaps that was the culprit. He is feeling better, but now he's complaining of aches in his knees and his ankles, and on exam, his left knee is mildly swollen and tender. How would you manage his symptoms? Okay, so many of you are going to check a uric acid, and because you're worried, I presume, about gout. And that seemed to be the most common thing that people seem to want to do. Okay, seems like we had a few less responses here, so I suspect that some of you aren't sure exactly what you want to do. So let's talk about joint-related toxicities. All right, so arthralgias are very common with pyrazinamide. About 8% have joint symptoms, and about 2% will end up having to stop the drug for it. You can see elevated uric acids. Unlike gout, allopurinol generally is not helpful. And whether or not to stop the medication depends on the severity of the symptoms. If they have severe symptoms and severe gout-like symptoms, you probably do have to stop the medication. Now, having had a history of gout is a relative but not an absolute contraindication to the use of pyrazinamide. And patients who have a baseline elevated uric acid without a history of gout, that's not considered a contraindication to the use of pyrazinamide. There are other anti-tuberculous drugs that cause joint symptoms. INH can cause arthralgias, as can fluoroquinolones. Ethambutol very rarely can also cause gout. I've actually never seen it, but it's described. But the other one that we worry about with quinolones is tendinitis and tendon rupture, and this is now a black box warning for the use of fluoroquinolones. The risk of tendinitis and tendon rupture increases with increasing age and concomitant steroids, and this is the black box warning. So usually if we're using fluoroquinolones for anti-tuberculous therapy, we're using it because we have a strong indication, but it's important to be aware of this risk, especially in elderly patients and those on corticosteroids. All right, I think this is the last of the cases we're going to go through. I did have some stuff in here on peripheral neuropathies due to isoniazid, and something about ophthalmology and ophthalmologic toxicity. Again, the only point I want to make here is that just like we are not dermatologists, we are also not ophthalmologists. And if a patient is complaining of eye issues, it could be from their medications, it could be actually occasionally a manifestation of their tuberculous disease if they have disseminated disease. So these are people that we don't mess around with vision and try and get them checked out as quickly as possible. Usually if you see a ethambutol toxicity, it tends to be painless and bilateral, and that's part of the reason why we screen. And the one thing that you can do is make sure that you've adjusted your ethambutol doses based on creatinine clearance. And another thing that is in here are rifampin hypersensitivity syndromes. We talked a little bit about flushing, and these may be more common with intermittent dosing. And on the bottom of this table are some of the less common manifestations that we'll see and which drugs cause them. QT prolongation, something we think about with fluoroquinolones, especially if they're on other drugs that affect the QT interval and cause QT prolongation. Bedaquiline is another one that requires cardiac monitoring. And then there are some drugs that can cause central nervous system side effects. Again, uncommon, but we see them. So here are a few key points. Adverse drug reactions are common on treatment for both latent TB and TB disease and can range from minor to major. Severe idiosyncratic reactions are rare but can have significant implications for treatment. Particular drugs may more frequently be implicated than others for specific types of reactions, but others can be caused by any of the first-line drugs. Monitoring includes risk assessment, client education and awareness, and ongoing open communication and documentation. All suspected reactions need to be addressed, but do not always require stopping or modifying the drug. And sometimes the drugs can, even after they're stopped, can be successfully reintroduced. And also, we are either generalists or ID physicians or pulmonologists. We are generally not dermatologists or hepatologists or ophthalmologists. So for severe and complicated adverse drug reactions, get help when you need it. All right, and here are some selected references. And I think that I'm going to stop sharing and we will address any questions that folks might have at this point.
Okay, great. Thank you very much. It was a great talk. We do have a question. I'm echoing a little bit. Is that bothering anyone else? Okay. First question is, since we count doses for treatment completion, how do we count doses when we stop drugs and add a drug back one at a time?
So the way we do it from a practical perspective is that as long as they are on 2 effective drugs, we consider that to be part of their effective treatment regimen. We don't count the days where they're off therapy, be that a week while you're waiting, or 2 weeks while you're waiting for the liver enzymes to improve. And if they're only on a single drug as part of a reintroduction, I generally don't count that. But as soon as they're on what I consider to be 2 effective drugs, I consider that to be part of their treatment regimen.
Okay, very good. Because I think that is confusing. Sometimes we wait until they're back on a complete regimen before we start them back. So that's good information to know. So I'd encourage anyone to type into the chat box if you have a question. And Olivia, do you have any more in the chat box that I haven't seen?
No, I don't have any others yet.
Okay. All right. We talked about, you might want to talk a little bit more about rifampin and the thrombocytopenia and pancytopenias. How often have you seen that? Because I've had a couple cases of of patients on just rifampin for LTBI that actually end up getting pancytopenia.
So
their white counts and their platelets were down.
Right. I mean, generally, I think we've seen more neutropenia than the literature would say occurs. And the question is, how low do you get that? How low do you let the white count go before you say, well, I better stop this? I mean, thrombocytopenia is obviously the one that's most commonly described, but we've also seen some drug-induced leukopenias. And the hematologic toxicities, there is the thrombocytopenia. I mean, they both seem to be manifestations of more of a generalized hypersensitivity reaction, and often they may have other mild symptoms to suggest that there are other systemic hypersensitivity components. And they generally, those patients generally also don't seem to do that well when they're given rifabutin if you stop the drug. Certainly the thrombocytopenia patients don't, and have not been super successful with the leukopenic patients.
Okay, I have another couple of questions there. Is there a maximum amount of days that the patient is not on meds, not on 2 or more meds, as you mentioned, before treatment has to be started all over again?
So I think it depends where in their course of treatment this is. You know, if you start them very early and you only get a week or 10 days of medication into them before you stop, and then you're stopping for, 10 days or 2 weeks at that point we sort of start the whole thing over again. I think the further they are into treatment, if you've gotten a month or 2 of treatment in, then that gap off of therapy can be longer before you discount, before you say you get no credit for time served and we have to start your treatment all over again. But I think that, I mean, there are rules about interruption of therapy for patients who are non-adherent, and we apply those same ones. For drug toxicity, most of the time we don't let them go that many weeks before we re-challenge. Or if they really have severe disease, we're not going to let them go that long because we're going to want them, we'll want them on an alternative regimen, even if it's only a temporary regimen, until we can re-challenge them with the original drugs.
Okay. And then I think our last question will be, 34-year-old female has a positive IGRA, and it was done prior to starting TNF inhibitors for her rheumatoid arthritis. She wants to continue birth control pills. What advice do you give her?
So the issue there is, if you are going to use erythromycin, then you are theoretically impacting on the effectiveness of her birth control. So the question is, you have the choice of using a potentially more toxic regimen that will require a longer course of treatment, like isoniazid, or ensuring that while they're on erythromycin, whether it's a 3-month or a 4-month regimen, that they're using an alternative form of birth control in addition to their birth control pills. Sometimes they're on their birth control pills for other symptoms to control endometriosis symptoms or other or heavy bleeding with their periods, in which case, if they're not using it for birth control, the consequences are much less. The issue is if that's their only method of contraception, then that's a challenge.
Okay, excellent. Okay, I think we're going to at this point in time. And we really want to thank you, Henry. It was an excellent overview of the side effects, so we really appreciate you taking out your very valuable time to present to us today. And I also want to thank everyone who gave up their time, because I know a lot of you, especially the nurses who are just inundated with COVID, taking your time out of your day to participate in this is really great, and we appreciate it. And we appreciate all that you do every day. And so Olivia is now going to share just a few final reminders as we end this presentation. I'll turn it over to you, Olivia.